So, good afternoon, everybody. My name is Viru Kassivas-Vanathan, and I'm chair of the Burst Research Collaborative. I'd like to introduce my co-chairs, Tamer Shah, Urology Registrar from London, and Kenneth Mackenzie, Urology Registrar from Newcastle. So I'd also like to welcome our followers from around the world, because this session is being live streamed on Twitter and YouTube as we speak. So I'm going to start off by giving an overview of the Burst Research Collaborative and some opportunities for people in the room. I'm going to move on to talking about Identify, which is one of the studies we're running at the moment. Many of you guys in the audience will be contributing to that. So 3 years ago, when I first started to think about the Burst Research Collaborative, as we know it today, I had some hopes for what we could achieve, so it's with great pleasure I can actually tell you what we've managed to accomplish in the last few years. So gone are the days when a trainee would carry out a small research project on their own with limited supervision and guidance. Doing things like that is difficult. Why don't we use a network which has a team of people with expertise in carrying out and delivering multi-center studies and developing those ideas to ones that can be practice-changing. The key concept is that each trainee contributes a small amount, but collectively to a common goal. That allows large-scale projects to be delivered quite quickly. And we've developed this network within Burst, which, although it stands for British Urology Researchers, is actually now an international network of trainees, consultants, and allied health professionals who are interested in delivering multi-center collaborative research. And again, the key concept here is that the trainees lead and deliver these ideas. So British Urology should really be proud of its trainees. We're the first trainees to really push this idea forward in urology. We've even changed our CCT guidelines for becoming consultant urologists to recognize people who contribute to these projects. And it's no coincidence that this is the first session, I think, ever at BAUS that's being live streamed across the world. So I must thank the committee who have put many hours of hard work into this, and along with that, the advisory panel and many of people who aren't even on this page who have contributed immensely to our success. We've also got some national coordinators in other countries who have been particularly useful in expanding projects such as Identify. So what makes us unique? Well, we have a robust peer review process, which allows us to take an idea from the back of an envelope to one that we can develop into a project that we can roll out. We have experience and infrastructure and manpower to deliver these ideas on a larger scale. We want to take you from being this person here to this. We know that doing this has advantages. Collaborative research can improve the quality of work produced. When it's been well thought out and peer-reviewed by experts in the field, it does tend to produce better results. You can get large numbers of patients quickly, and this has benefits to the individuals taking part in the research who gain research methodology skills from doing this, which equips our future workforce to deliver clinical trial research. It also benefits the unit who have a set of trainees and a unit with a experience of producing studies. And most importantly, it benefits the patients. One such example is MIMIC, one of the presentations of which you heard this morning in the Best of BAUS. To our knowledge, this is the largest known contemporary cohort assessing outcomes from acute ureteric colic. And I'm going to take you through this, which gives you a good example of how our projects work. So we know there's conflicting evidence in the role of inflammatory markers in spontaneous stone passage. And if there was a biomarker that could help clinicians guide whether or not patients pass their stone, that would be a useful tool to manage these patients when they come into A&E. So we carried out a multi-center cohort study in patients with CTKUB confirmed acute ureteric colic, assessing whether white cell count did influence spontaneous stone passage. A secondary aim was to look at the role of medical expulsive therapy. We recruited 4,181 patients from 71 sites in 4 months. That proved that the trainee-led collaborative idea worked. And again, thank you to our collaborators, many of whom are in this room, who contributed to this data and made it possible. So this is an example of how I use the mimic data in my daily practice. When I have a patient coming in with renal colic sitting in front of me, I use this graph, which has spontaneous stone passage rates according to stone size. And I use that information, the chances of a patient passing a stone of a particular size, to inform the discussion I have with that patient. We know from mimic that white cell count was not significantly associated with spontaneous stone passage, that size and position were the most important factors, and we heard this morning that medical expulsive therapy did not influence spontaneous stone passage. And this information is being used to develop a risk calculator which can help guide clinicians in managing their patients. This work has allowed trainees who are collaborators present this all across the world, and I dread to think how many air miles we've racked up over the past 3 years. That's one thing we haven't calculated. What we have got is recognition from international scientific conferences, from our peers who are experts in the field, and from international journals. And in the last 3 years, we've had 12 presentations, 8 prizes, 5 publications, and involved more than 1,000 collaborators. We don't just do research, we also teach people how to do it. And one of the things we have on our website now, led by our education lead, is an educational video series, which teaches urologists and trainees alike basic research methodology to enable them to carry out and design the projects that they want to. And this is all free. We've also collaborated with the National Institute for Health and Research and are delivering urology-themed good clinical practice training courses around the country, and this is something that will enable trainees to recruit patients to clinical trials. So over to you. So you have the opportunity to lead your own project under the supervision of the BERST team, and we allow projects to be submitted all year round. If you go onto the website, there's a means of doing that. And there are also other opportunities like today, where we have a Dragon's Den session where we can try and find maybe the next idea. One project I wanted to mention was a service evaluation project, kindly sponsored by Ferring, which is due to launch in the next few months. And it's looking at patients started on androgen deprivation therapy. We know that these patients have a higher cardiovascular morbidity, and we want to see whether or not clinicians currently who start patients on this treatment assess their risk properly, and what their current practice is in terms of methods of castration and their 1-year cardiovascular morbidity. This will be a multi-center service evaluation, and there are opportunities for people to get involved in data collection locally. And again here, the emphasis is on a small amount of work for each trainee, where we'd ask trainees to collect data for up to around 20 patients each. There are also opportunities for this project to lead the project and be on part of the steering committee. Critical appraisal, being able to understand the literature, is also an important skill, and we've formed collaborations with a number of journals. If you wanted to get involved in some peer review and gain some of those skills, we can put you in touch with the relevant people. We've also formed a collaboration with the BJUI and are inviting trainees to produce podcasts summarizing key pieces of research which will be published in the BJUI. There are opportunities for trainees to join our committee. In terms of this job, it's an 18-month post. We do require you to have time to set aside in your evenings and weekends, and dedicated academic time does help. What you'll find is that the people who have joined our committee, as you'll find out later today, have really gained a lot from doing that. As well as gaining research methodology skills, you'll be part of a great team and be able to work as part of that team to develop everyone's ideas. In summary, there are a wide range of different types of projects and opportunities being carried out by BERST. I only had 10 minutes today, so I couldn't go through all of them, but most of them are listed on our website. At BERST, we really want you to move from being consumers of research to producers. And I would love to continue this discussion further at dinner, which is being sponsored by Ferring tonight. And I think Kenneth has a few places left, but not many. So at the end of the whole session, if you speak to Kenneth, he can confirm whether or not there's a place free. I'd like to thank our funders and supporters over the years who have helped us to get to where we are, and we'll hand over to my co-chairs. Thank you.
Thank you very much. So the next 20 minutes or so will be us giving 2 talks updating on our latest project, Identify. If we could all hold our questions till the end, we will send the mic around, and you can also use the app to send us your questions. And I was going to invite him, but he's already up on stage. Sinan Kadiri, he's the lead trainee for Identify, based up in Scotland.
Thank you, Taylor. Good afternoon, everyone. I'm honoured to be giving this short talk to update you on our exciting international collaborative study, Identify, the investigation and detection of urological neoplasia in patients referred with suspected urinary tract cancer, a multicenter study. I say exciting because this is, to the best of our knowledge, the largest prospective study on hematuria in secondary care. Over the years, various studies have shaped the way we investigate hematuria. Edwards et al. Advocated ultrasound for upper tract imaging with IVU for selected patients. Kadra et al. Concluded that cystoscopy should be considered in all age groups, including less than 40 years of age, and that only ultrasound and IVU together captured all upper tract disease. Moving forward, more recently in 2015, NICE referral guidelines for suspected cancer have been updated, essentially raising the threshold for referral. But what impact has this had on our diagnostic yield? We don't know as yet. However, there's still no general consensus on how best to investigate hematuria, and different hospitals, different clinicians will have different diagnostic practice. I would argue that our patient presenting with hematuria is of relevance to each and every one of you here, consultants, junior doctors, specialist nurses, and of course patients. This study will help us to make better clinical decisions. So we designed a multi-center international study to provide a contemporary picture of patients presenting to secondary care with hematuria and looking at their diagnostic pathway and outcome. We would then be able to assess current prevalence, especially in light of the new NICE guidelines, and evaluate current practice. We hope this may allow us to recommend changes in cancer diagnosis pathway that may reduce the number of invasive procedures, reduce waste of resources, and optimize use of the most appropriate tests. This graph really is a testament to the phenomenal power of the Trainee Research Collaborative. Data recruitment started in December 2017, and here we are 6 months later with 7,500 patients and still going. Currently, we're in the final stages of data collection, and we anticipate the data will mature and be ready for analysis by December 2018. To give you an idea of the geographical distribution so far, this is a global study which started in the UK, but includes Europe, North America, Australia, South America, Asia, and even Africa. So we're just about on 6 continents. There's over 175 sites and well over 400 collaborators. So homing back into the UK, we have a current snapshot of UK diagnostic practice in 73 hospitals, which, as you've seen from the map, is representative of almost every major city. So a large proportion of hospitals have a one-stop hematuria clinic where assessment, history, and examination, flexible cystoscopy, and imaging are performed on the same day. Just under half do routine PSA testing. First-line imaging for visible hematuria is dominated by ultrasound, then closely by CT. In second-line imaging, CT is the most common investigation. Interestingly, a third do not perform any second-line imaging in visible hematuria. First-line imaging for non-visible hematuria is unsurprisingly dominated by ultrasound, and second-line predominantly with CT. 22% did not perform any second-line imaging. And so, on to the interesting part. Please note these are preliminary results only, and these may and probably will change after data completion. So bear that in mind when drawing any conclusions from them. So far, we have a population set that is similar to our pilot study and previous published literature. We've had more men referred than women, and a median age of 66 years. If we divide our population by type of hematuria, we can see most of our patients are being referred with visible hematuria, but approximately a third make up non-visible and no hematuria referred with suspected cancer. Looking at our pickup rate of cancers, again, this is similar to our pilot study and to previously published prevalence rates. Bladder cancer rate was 14.6%, upper tract cancer 1%, renal cancer 1%, and prostate cancer 0.8%. The relatively large numbers of the rarer cancers will give us enough power to analyze these group of patients and try to understand why they have these rarer cancers. Regarding other disease in our cohort, 18% of patients had a UTI, stones accounted for 10%, and interestingly, bleeding prostates accounted for 17%. Just under half of those patients were anticoagulated. Interestingly, 8% of the 18% had bladder cancer when they presented with UTI. Looking at individual cancers by various risk factors, bladder cancer had a higher rate in visible hematuria versus non-visible hematuria. Interestingly, non-hematuria had the highest rate. This is clearly an interesting group of patients that will need further analysis. Renal cancer rates were also higher in those with visible hematuria versus non-visible hematuria, as was upper tract cancer. The highest rate of prostate cancer was found in those with hematuria, again, a group that needs further analysis. Looking at smoking, urothelial and renal cancer rates were higher in smokers, but seemed similar in prostate cancer. Interestingly, rates of cancer in those that are anticoagulated are higher. We also took a look at some less understood risk factors, such as BMI, where cancer rates were highest in the obese group, and also cancer rates in different ethnic groups. And unsurprisingly, there were higher rates of cancer in those referred from inpatient episodes and from the urology department. Looking at the group of pathologically confirmed bladder cancers in our study so far, the majority of these presented with visible hematuria as expected. They were more likely to have a smoking history, and there was a higher rate in men. Incidence peaked in the 70 to 79-year age group. Some other interesting characteristics in this particular cohort: 3% had positive family history. 4% of these patients were investigated within 3 years for hematuria, some even within the last 6 months. Could this be an indication that we're missing tumors or very early disease? This is something that's not been looked at before. 8% of this cohort had a UTI at time of hematuria, something we'll look at in the next slide. And the CT pickup rate of bladder cancer was 84%, but this hasn't been broken down into contrast versus non-contrast scans. So, although data collection is incomplete, we looked briefly at the missed cancer rates if we stuck stringently to the NICE guidelines. NICE recommend investigation of those aged 45 years or older. We found an overall cancer rate of 5% for those in less than 45 years old. If we looked at visible hematuria with a UTI that had resolved after treatment, we found 10% of bladder cancers were missed. In the over 60s category, 6% of those with non-visible hematuria without dysuria or raised white cell count had bladder cancer. Renal cancer referral guidelines are similar to those of bladder cancer, and if we looked at the overall cancer rate, including renal cancer, for the group with visible hematuria and UTI, it was 6%. So, in conclusion, Identify is a very exciting study, and it's the largest of its kind, looking at hematuria in secondary care. We've got a good pickup rate of cancer. It provides interesting patient characteristics and risk factors that have not really been looked at before on such a large scale. And it asks certain questions like, is categorizing patients to visible versus non-visible hematuria enough? Do guidelines need to take in other risk factors? What about the age threshold? Can we predict which patients are at high risk of different urinary tract tumors? So watch this space. The data presented today is just the beginning. With our extensive analysis plan, we hope to have some interesting results for you and answers to some difficult clinical questions. Of course, none of this work would be possible without all the collaborators that have helped, which I have tried to squeeze on. Thank you very much for listening.
Sinan, thank you for that sneak peek, and I'm sure we all agree that we're looking forward to the full data set coming out. I'd like to invite Kevin Gallagher, MRC Fellow from Edinburgh, to tell us about the future of Identify.
Good afternoon. Thank you for giving me the opportunity to talk to you all. The investigation of hematuria is something that there's a lot of debate about, and I won't go into the debate specifically in too much detail, and I hope that you can all attend the session which is on Wednesday morning, which will go into a lot more detail about that debate. But what I'd like to do is, you and all of our collaborators worldwide have excelled in collecting so much high-quality data that we would like to give you a glimpse of what it is we plan to do with that. So there are two key and quite separate questions in the investigation of hematuria. Who to investigate is a question which almost all of the national bodies make recommendations on, and they differ slightly in the age at which they recommend urgent investigation for hematuria. Identify is more concerned with the question of which investigations for which patient. So what do we know already? Blick undertook a detailed diagnostic study looking at patients aged greater than 40 with visible hematuria and concluded that the best diagnostic strategy was to perform a CT urogram up front as a triage to either rigid or flexible cystoscopy. And of course, we've had the recent publication of the DETECT study, which showed that in visible hematuria, there was a significant rate of cancer in those aged less than 45, somewhat contrary to the NICE guidelines. And Tan was suggesting that all of these patients should have cystoscopies because of that risk. In patients with non-visible hematuria, Tan also found a significant rate of cancer in patients aged less than 60, but agreed that ultrasound scan can replace CT for investigation of the upper tract in these patients. Halpern performed a really large analysis of multiple studies looking at asymptomatic non-visible hematuria and showed that if you were to perform a CT urogram rather than ultrasound scan for these patients, you would detect one additional cancer for every 10,000 patients at a cost of $6.4 million. So clearly there's some controversy and debate in this area. And accompanying the Tan paper in European Urology was an excellent editorial by Yair Lotan from Dallas that said, the question is, how do we improve referral and evaluation of patients with hematuria? And the answer is risk stratification. And that is the big idea of Identify, personalized hematuria investigation. Identify aims to provide recommendations on investigative pathways in urinary tract cancer based on individualized risk and marry that up with the diagnostic test performance. So what we really want to do is go beyond age and hematuria type, because that's how we split up investigations as it currently is. So you might imagine the situation where perhaps a young low-risk patient just has an ultrasound scan of the kidneys and bladder, and we say we don't need to do any more investigations for you. What that patient's going to want to know is, what is the chance that I have a hidden cancer that the test didn't pick up? And what we will need to know to answer that question is the negative predictive value. And the negative predictive value is crucially dependent on the individual risk or the incidence in the population that you're studying, together with the diagnostic performance of the test. So if we want to go beyond age and hematuria type, you need a large prospective study that's been well planned to answer this question. It collects detailed baseline demographic and risk factor data, as well as presenting complaint data, and predicts individually the risk of each of the different kinds of cancers. And that's important because each of the different kinds of cancers requires a different test. This is teamed together with the diagnostic test performance, and then you begin to be able to make some personalized recommendations. And we spent a lot of effort and time in getting the data collection for this right by working together closely with the National Diagnostic Test Evaluation Unit in Birmingham under Susan Mallett and John Deeks. So let's say we had a 41-year-old male with visible hematuria. He'd had one episode and no other risk factors. We've got studies emerging now that say that people aged less than 45 with visible hematuria have a risk up as far as 4% of having a urothelial malignancy. But we put his details into a risk calculator and it tells us that his particular baseline risk is fairly low. Does he need any investigations? We decide to do an ultrasound scan of his kidneys and bladder, and the diagnostic performance of the ultrasound scan has been determined to be thus. You apply that to his baseline risk, and now his risk of having an undetected cancer is even lower. And this is the negative predictive value. You can tell that patient he's got a 1 in 800 chance that there's a hidden cancer that we haven't seen. And that chance will be different for every patient based on what their baseline risk is. And that's why we need these detailed risk predictions. So really what we're doing with identifying what we've already begun to plan is an RCT of personalized investigative pathways for hematuria versus standard of care. The primary outcome would be cancer detection rate, and we would have a hypothesis of non-inferiority that personalized investigation will result in no worse cancer detection rate with a lower investigative burden than standard of care. Thank you.
Thank you, Sinan and Kevin, for those nice talks. So at this stage, there is time for about 2 to 3 minutes of questions from the audience. So if I can open it out to the floor for any questions for Sinan and Kevin. John?
Thanks very much. So great presentations, and you already know I'm very excited about the work that's going on, and really interesting early view of what you've found. One of the things I think is highlighted, which I just wondered if you thought about looking into further, is the primary care angle. So your patients who are being referred off protocol have been screened by GP, so they are highly selected, and we know very little about that end of things, and that might be hard to reach back, but have you thought about how we could add any data in that end?
That's a really interesting point, and I think certain groups, for example, the non-hematuria group that had such a high rate of bladder cancer detection could be due to, the clinical acumen of GPs. These are patients who haven't had hematuria, but there's just something about them that the GP is still referring in for. So that's something we'll certainly be looking into.
Okay, one last question here at the front.
Hi, thanks. Just following on from that, the non-hematuria group, isn't that largely containing patients that have had positive imaging from the GP?
So yes, that will be a mix between some patients who've had incidental finding of cancer and imaging, but also patients that are presenting with LUTs, ongoing LUTs, for example, recurrent UTIs, and there's a clinical suspicion of cancer.
The incidental finding group there is quite small in those figures. It's mostly LUTs.
Okay, thank you very much, both of you. So for the next 10 minutes, this is an opportunity for the BURST committee to stand up. So if I can ask you guys to line up now. And they're going to tell you a bit about what they've been doing over the past year with a quick 1-minute turnaround between people. And this is, again, a chance for everyone in the audience to see what people do when they're part of BURST and what they can learn from it. And it's a time for reflection. And if you're interested in joining BURST, maybe you can listen to what they say. So if I can have the first person up, please.
Good afternoon, everyone. My name is Arjun Nambiar. I'm a Urology ST5 in the Northeast, and I'm the education lead for BURST. And Viru's already stolen my slides, so I really don't have much to say, actually. But no, in all seriousness, what I do have to say is that, as Viru mentioned in his introduction, this year has been largely about creating these series of educational videos, of which we've got 4 uploaded now to YouTube. And they're all, as he said, freely available for everyone to view. And that process will go on over the next 12 months, and we plan to add to that, hopefully coming up to a series of about 10 to 12 videos at least, and we're working with some of the research collaborative groups in the UK to produce those. But what I would say to you guys today is that this shouldn't just be about us putting forth what we think people need to know about research methodology and statistics. So if you have anything that you think you want to know about, things that you struggle with, or things that you think would be useful, please let us know so that we can incorporate that into the videos and get all that out there. So thank you very much.
There we go. I'm Eleanor Zimmerman. I'm a CT2 currently based in the West Midlands. And I'm going to talk to you about what I've done as a core surgical trainee representative. Now, the opportunities that we have as a CT rep basically allows us to engage in a wide range of activities that BURST is involved in. Firstly, obviously talking about Identify, which is the big project that we've been working on this year. As a team, we were all involved in the internal protocol review, but also the planning surrounding the REDCap data collection process, and also the ongoing quality control, so contacting sites when necessary for clarification or additional information where required. From a communications point of view, we've been working very closely with Kevin to reach out to as many core surgical trainees as possible, both through contacting training program directors, but also at specific events, for example, the BAUS core urology course earlier this year. I've also been very heavily involved with the website, not only updating the current one, but also with a sub-team building a new website, which we're hoping to publish in the coming few days. But aside from all of this, I've also been given the opportunity to attend meetings, such as with the National Institute of Health Research, which has allowed an invaluable insight into the current research trials that are ongoing in the UK. What I really want to end on is by saying that being part of the BURST committee has allowed an invaluable understanding of the workings behind a successful international collaborative, but perhaps most importantly has highlighted the power that we have as surgical trainees to collect high-quality data with the potential to change clinical practice. And on that note, I really want to urge any enthusiastic core surgical trainees amongst you to apply for the position when it becomes available in the coming few weeks. Thank you.
Hi, I'm Eric Edison, similar to Eleanor, core trainee rep, currently working at North Middlesex in London. So we've had some similar roles being involved with Mimic and Identify. So with regards to Identify, as Eleanor said, we all have input into the protocol and the piloting of the data collection. Also had some input into the quality control of the data collected itself. With regards to Mimic, I presented that at a national conference. In terms of other opportunities we've had which have helped to develop my skills, I've been helping with funding applications, which have been really valuable experience, and other things such as putting together the newsletters. So anyone who's thinking about applying, it's a really great opportunity and will help to develop your skills.
Hello, my name is Kenneth McKenzie. I'm a ST4 from Newcastle. Other than falling off the stage, I actually do things within BURST. So I've been helping a lot this year with the coordinating of UK sites. I'm also the guy that's in charge of chasing all of your site data for Identify, so the one in control of all the emails, so sorry in advance. I've organised the Dragon's Den session today, and thank you for everyone that submitted an application for that. And involved in Slack comms, which basically means just communicating all the time about every project that's going on within Burst. It's quite an upkeep, but it's actually very good to be involved in. As I say, the main thing is being communication, and it's a highly effective team and a lot of committed people within it. So yeah, it's great to be involved in. Thank you.
Hi, Kevin Gallagher again, Research Fellow and Registrar in Edinburgh. So I've been intricately involved in the Identify study, and that really is one of the big benefits of Burst for somebody at my level. You get on to the committee which is designing and running these studies. So we co-wrote the protocol, co-produced the REDCap database, which took 313 days to make. I coordinate the international sites, of which there are 106, so that's lots and lots of emails. I run our Gmail account with over 800 contacts, and I introduced the Slack software for us, which is a team working communications app, which has really streamlined how we do things. We've sent each other 14,000 messages on that this year. I oversee the Twitter account with lots of help. We now have over 1,000 followers and generate 30,000 impressions per month. It's got so busy that we now need an app to help us run the app called Hootsuite. And we won this award this year, which Fever told you about earlier, which I'm very honoured to have received. And really the biggest thing that I learned this year is that when you're completely out of your depth, as I was with social media in general when I started, that you really need a good team behind you who have more skills than you do. And I thank Sasha, Eleanor, and Eric for all of their help with that. Thank you.
Hello there, my name's Lindsey Williams and I'm one of the medical students representatives. So I've just completed my degree at St George's and I'm about to start F1 also at St George's. So whilst on the Burst Committee, I've learned a huge amount personally about how research is carried out by collaboratives. I've had the opportunity to not only collect data myself, but I've learned valuable research skills such as quality control, which we've all been carrying out for Identify. On a personal level, I've also been able to explore urology more as a specialty because it was an area I was interested in, but at my medical school we only get 1 week of urology, so I found that really useful as well. I wanted to know more about it as a career path. So one other project I've been involved with is the creation of a YouTube video. So that's been aimed at medical students and basically aimed at offering them more knowledge of Burst, what we do, but also the opportunity to get involved with us and to get involved with international projects as well. So I think I've learned a huge amount personally from being on the committee and would also like to thank the senior members for their mentorship as well. Thank you.
Good afternoon, everyone. My name is Sasha Moore. I've just completed my studies at Southampton Medical School and have had the privilege of being one of the medical student representatives on the Burst Committee. So reflecting on my time at medical school, I think joining Burst is up there as one of the single best things I've done. I've had a range of opportunities offered to me, including being a part of Identify and learning a great deal, not only about multi-centre study design, but also the huge logistic effort that goes into running something on Identify scale. I've also taken a role on the communication sub-team, as Kevin alluded to, developing our use of social media and finding ever more technical ways of engaging with our supporters and collaborators worldwide. But without a doubt, I think it's the guidance from the other committee members that I have valued the most, be it discussion over methodology or support in academic job applications. I'm very grateful to the fantastic team for their words of wisdom and constant encouragement. I hope to continue serving on the Burst Committee in the future, and to any medical student who is watching, who is considering urology or surgery, I cannot recommend getting involved with Burst highly enough. Thank you for listening.
So, Sinan Kadori again. Identify study lead for Burst. As you can imagine, Identify takes up a lot of time, but I have learned so much through this project. A lot of what has been said, I'm just going to mirror in terms of protocol writing, learning how to apply for grants, answering endless emails, quality control to make sure that you're all putting in your data properly. It's a love-hate relationship. And also getting the opportunity to present our Identify summary in big conferences such as BAUS, EAU. In essence, it's been eating, sleeping, and breathing Identify. Outside of this, I have had the opportunity to present our other work, Mimic, and was pleased to win the ACIT SARS Prize for BURST for that. Thank you very much.
Hi, good afternoon. So my name's Tamer Shah. I'm the Vice Chair of BURST and a trainee in London. And for those of you who know me, 1 minute really isn't enough for me to give any talk. The last year's been a big year for BURST, actually. I've been involved for a few years, but we finally completed our first project, Mimic, which you've been hearing about from Viru and also from Nazrin in the morning. With it came publication of our protocol, but also we've been able to present it internationally in places such as Canada, Australia, France, Ireland. And it's not just been the committee. It's one of the best things I've seen is that we've been able to send trainees who have collaborated on the project to all of these places to actually go and present our data, similar to Nazrin this morning. And the next big step will be our first data paper, which is hopefully going to appear in press very soon in we hope, a high-impact journal. Alongside Mimic itself, been involved with the committee designing a future RCT based on the data. We actually presented it at a National Research Collaborative Conference and came runner-up with the idea. On top of that, we have the Identify project, which I've been involved with in the protocol development and some of the delivery. Been involved in a very soon-to-launch project looking at cardiovascular disease with androgen deprivation therapy. And alongside that, also have been involved with website design and maintenance with Eleanor and Chanyu, who couldn't be here today. I think it's been a brilliant few years. I hope to see BURST continue growing. It's gone from a handful of committee members to a big committee and thousands of international collaborators, and I think this bodes well for the future. Thank you.
Okay, so I think when you look at an organisation from the outside, sometimes you wonder how it works. And I hope that's demystified how BURST works and also demonstrated the breadth of work that we do and what we do on a day-to-day basis. And most of these people who you saw have full-time clinical jobs. So I hope it demonstrates what's possible to achieve and the fact that it can be fun. And I'd like to thank each and every one of them for their hard work. Okay, so I'm going to hand over to Kenneth now, who's going to introduce the Dragon's Den session. Kenneth, over to you.
Hi, as I say, my name's Kenneth Mackenzie. I'm in ST4 up in Newcastle. Could I ask the Dragons to come up to the stage, please? So we've got Mr. John McGrath, Professor Graham McLennan, Mr. John Anning, and Viru Kazai Viswanathan. I've been practicing. Up at the front, thanks. So, Dragon's Den, we've got 3 presentations today. The speakers have 10 minutes to present with 5 minutes of questioning. As I said before, thank you very much for all the submissions. We had 12 submissions this year, which I believe is a record, so, and they were actually all very high quality, so it's brilliant. So today what we're looking at again is looking at the novelty and the feasibility of these potential studies and to try and take them on as potential future BURST projects. So as I say, with regards to voting, we've got the winner is going to be made out of 5 votes, 4 from the Dragons, and then the audience and our viewers online will also be voting as well. So if you use the BAUS app, then you can vote for who you think is the best presentation or best project. And there is also a Twitter poll. This is how you do it, but I think we're all tech savvy, so we'll push through. So, as I say, we've got 4 Dragons who've given up their time for today. So, we've got Professor Graham McLennan. He's a Professor of Medical Statistics and Director of the CTU Aberdeen University. His main research focus is designing fair tests and healthcare treatments, and he's been extensively involved with numerous urology projects. Next, we have Mr. John McGrath, who is consultant urologist, specialising in pelvic oncology in Exeter, and he's actively involved in BOWS, being the chairman of the BOWS section of academic urology, and also on the executive committee of BOWS section of oncology. And then we have Mr. John Anning, who's a consultant urologist, again specialising in pelvic oncology, and I know him from a time in Newcastle, but he's now just moved down to Bristol, sad to see him go. And he's a member of the BOWS section of academic urology as well. And then finally, as mentioned, we've got Viru Kazai Viswanathan. He's the chair of BURST, and we've all given a presentation today about our role, but I think he's actually just the driving force of it all. I mean, none of this would be possible without his involvement. So, yeah, very impressive. He's also just recently published something, a small paper in the New England Journal of Medicine, but less about that. So, as I say, we've got three presentations today. First, we've got Joseph Norris from Northwest London, who's going to be talking about Uber. It's not a taxi journey. We've got Simon Morton from the Northeast Deanery, who's talking about some scrotal explorations, and then Nikita Bhatt, who's come over from Dublin to talk about the role of stents in urolithiasis. So, if I could ask Joseph Norris to come up to present his first his presentation. Thanks.
Thanks, Kenneth. Just waiting for my slides. So I'll introduce myself. I'm Joseph Norris. I'm an academic urology ST3 registrar from London. And it's a great privilege to be invited to present today, so thank you very much to everyone. My presentation today is on Uber, and as you said, it's not a taxi journey. It's a prospective, observational, multi-centre cohort study looking at the management of acutely obstructing stones. A particular facet that I'm interested in is the differences that probably occur between our classical management, that's stenting, and then delayed management, between those lucky individuals that get upfront definitive URS. And I'll go through what that means. Just to introduce the other people, Mark Emberton is my educational supervisor. My co-supervisors are listed here, and if you're interested in following me, my Twitter handle is at the bottom there. So just to outline my talk, I'll give you the background of the trouble that stents and stones cause, and I'll put this into context of the recent MIMIC trial, which you've heard about today. I'll then deliver my proposed methodology, and this will be in the classical PICO format. And then finally, I'll give you what I think are really important potential outcomes and headlines that could come from Uber. So the background for this study. As we all know, urinary stones are extremely common. About 1 in 10 and about 1 in 5 ladies. 1 in 10 men and 1 in 5 ladies are affected with stones, and they have huge ramifications, including sepsis, bleeding, renal failure, and even death. There's a dichotomy here because with renal stones, there's a perception that they're of lower clinical and academic priority, which I believe is incorrect, and it's something we need to fight as a urological community. Now, the MIMIC study we've heard about today is a fantastic success of BURST. It was their inaugural study conducted in 2016 and 17. And again, this focused on urinary stones as well, even more so ureteric stones. So BURST demonstrated with the MIMIC study that approximately 75% of patients passed their stones spontaneously, whereas 25% required intervention. Now, it's this particular sub-cohort that I'm interested in, and I think it's this set of patients that we could do better for. I think there is a huge scope for improving their clinical care. And if I'm honest with you, I think Uber could be the sort of intellectual child from MIMIC, and I'll go into that later. So I'll give you some clinical case studies to keep you interested. 2 cases, both quite similar. So case 1 is a young lady with an obstructing ureteric stone on the left-hand side. Case 2 is a chap with, again, an obstructing ureteric stone. Both similar in their presentation, and both did not respond to conservative management. Both warranted us to act surgically. Unfortunately, both their management was very different there as a highlight. So case 1, the young lady, she was added to the CPOD list, and a ureteric stent was inserted. 4 months later, she underwent a URS and destruction of the stone, and she was declared stone-free at 16 weeks. And so over the 16 weeks, she suffered with pain and bleeding, infection. She just had a really miserable time. Case 2, though, was a much more fortunate chap, and he was added to an elective, concurrently running urology list, and he had definitive URS on the first day of presentation, and he was declared stone-free in 24 hours. And so you can see the differences between these two cases quite stark. And I'm slightly embarrassed to say that case 1 is the standard of care in the UK, and that's case 2 is really quite a rarity, it's quite uncommon. I'm going to go a bit further, and I've added an adjunct onto case 1. I think that's poor. I think we can do better, and I think we should do better for these patients. I think we've got a duty to do better for them. So I think where possible, we should be pushing for case 2. We should be doing primary definitive treatment for these patients. So back in March, when I was doing my Registrar of the Week on call, I stented numerous patients. I even tweeted about it, and I generated some response from a Scottish consultant who said he was a bit disappointed in me. He didn't want me to do back-to-back stenting. He wanted me to be doing back-to-back ureteroscopies. And actually, I discussed with my colleagues and my consultants, and their feeling was the same. There is a hunger from urologists to do more for patients when they're treated, when they present and when they're diagnosed with stones. So I turned to the evidence. I found there's actually huge paucity of evidence in here, in this field. Anecdotally, we find that these patients do a lot better, but in the literature, there isn't the evidence to support this. So hence I designed UBA. The hypothesis for UBA would be patients which are treated definitively immediately do a lot better than those patients that get delayed management for a myriad of reasons, largely due to the complications that are related to the prolonged stent dwell time. The null hypothesis would there be that there's no difference between those who are treated immediately and those who are treated in a delayed fashion. The aims of UBA would firstly be to delineate the differences between these two cohorts. Secondly, to identify the barriers to delivering immediate treatment, and this might be a lack of laser equipment, a lack of laser-trained staff, or a lack of ureteroscopes. And thirdly, it'd be interesting defining the regional and international variation between the management of obstructing ureteric stones. So the methodology for this study, let's use the traditional PICO method. So P, the population of UBA, would be adults with unilateral obstructing stones. It would exclude children and those with transplant kidneys, single kidneys, and those who are just unfit for treatment, so whether they're profoundly septic or whether they're medically unfit for other reasons. Now the I is for intervention. It doesn't quite fit for this because I mentioned this will be an observational trial. However, for argument's sake, we could say immediate URS within the first 24 hours would be our I. Now the C is for comparison, and for argument's sake, we could say nephrostomy or stenting in the first 24 hours with delayed URS. Now the O is for outcome. After much deliberation, I decided that my primary outcome should be the utilization of healthcare. So I'd be interested if anybody has any useful metrics for this, and it might be inpatient stay, it might be cost incurred. Now the secondary outcomes are equally important here. So this would be adverse clinical events, so sepsis rates, hematuria rates, but also rate and time to being declared stone-free. So this is the Gantt chart. This is the timeline for the UBA study. If we're given the green light for the UBA study, we'd begin later this year and take a small number of registrars across a small number of hospitals, and those trainees would then document the myriad of stones that are referred to them and put them all in this fantastic system that we've heard about before called REDCap, which is the online system that we've used for the Identify trial. Later, toward the end of the pile, they then go back and reassess these patients and see what would their clinical course look like. Did they have any complications? Were they treated immediately? Were they treated late? If the pilot's successful, we then go on to recruit various centres. We could do this over social media, we could do this at conferences, we could do this at regional teaching days. Phase 1 of the study would then be trainees, hopefully worldwide, in the same vein as Identify, would then go on to document all the ureteric stones that they've been referred and capture them within the REDCap database. Phase 2, toward the end of next year, would be then the return to all of these patients and see what happened to them, what was their clinical course, and were those that were treated immediately, did they do better compared to those that were treated later? Final stage would be the analysis and reporting. So this is my final methodology slide now. Ethically, I've run this through the R&D department at Northwick Park Hospital, and I've had confirmation that this would constitute a service evaluation, which is fantastic news, as it means it doesn't have to go through formal ethical committee and really would allow us to run this at a quicker rate, at a wider span. Funding, similarly, this wouldn't really require any formal funding per se, as the REDCap system is free for university users, and treating stones is something that we already do. Statistics, I've involved a statistician at UCL who's helped guide me through the various different statistical tests that are warranted for the different outcomes that I've identified. So just to summarise, a huge congratulations to BURST. They've done fantastically for both Mimic and Identify, and this map just shows you how far the span of centres for the Identify trial is. So I think the time is now to strike while the iron is hot. I think Uber's got to be the next trial for BURST to take on. We've got to continue the momentum and the success that BURST have had. I think Uber, above all, is perfect for trainee collaboration. As trainees, we're the ones that see the patients, and often we're the ones which treat them in the first instance. Stone disease is hugely relevant, and I think the observational design of Uber is perfect for BURST to embrace. The potential outputs of Uber are huge. As I mentioned, there's no large, robust evidence in this field, and in a way this could drive practice change in the future. And it would also answer multiple clinical questions that we've been asking. What are the ramifications of prolonged stenting? What are the barriers to delivering primary ureteroscopy acutely? For trainees, this would also be useful. The high-quality audit conducted would be useful for our ARCP. The multiple publications that would stem from this would help us with our CCT requirements. And finally, the data generated from this would help us design a future RCT. These are the few references for some of the things that I've been quoting. I'd like to thank you all very much for listening, and I'm happy to take any questions.
Brilliant. Thank you, Joe.
Thanks, Damon.
It's now time for his grilling from our dragons to decide if they would invest in Uber. And I think we'll start with Graham. I've been seeing him write pages for the last 8 minutes.
First of all, I don't believe that you spoke to a statistician, because no professional statistician would recommend SPSS. But I'm just playing for the game.
Apologies.
I was interested in the in Uber identifying what the barriers would be to implementing immediate treatment, because how will an audit tell you that?
So there's lots of different ways. So the trainees are the people on the ground, and they can discuss with the hospitals and the team and the consultants. We've got this patient who's got an obstructing ureteric stone. Why can't we treat them with a primary ureteroscopy? And the reason would come immediately to them. The CPOD coordinator would say, there's no laser, we have no staff that can use a laser, we've got a laparotomy to do. The reasons would be given to you instantly, and we document these all in REDCap and be able to collate them.
Yeah, okay, so I'm surprised that your ethics committee said that was an evaluation of the service, because now you're actually interviewing professionals.
Okay.
I think it's great if they've said that, but just beware that that now becomes almost primary research when you're actually eliciting people's opinions.
Okay, sure. I hadn't actually considered that as part of the protocol, but yeah.
Viru, any comments?
I'll never think about Ubers in the same way again. So you spoke about your observational study design.
Yeah.
How will you mitigate confounding factors in explaining some of the differences in the outcomes that you anticipate? And along with that, why would you not consider a randomized trial design for something like this question?
That's a really good question. I think answer to the first part of the question would be multivariable analysis. It would be really important to document all the different factors at play and conduct a multivariable analysis to dissect out the possible confounders. And in terms of why we couldn't do an RCT immediately, there are lots of reasons, and you know the difficulty of conducting surgical RCTs. One of the greatest one would be to my mind, there isn't equipoise between the two arms of the study. Stent and delayed management doesn't necessarily have equipoise to management immediately. In a strange way, I'd be fond of managing patients immediately, but you wouldn't be able to randomise a patient to either group. You put it to them, they would say, please just treat me straight away, don't delay me for, that you saw that lady, she was delayed for 16 weeks. It'd be very difficult to recruit for an RCT. Lots of other reasons, but I think that'll probably be the top of the list.
So that leads me on to my next question. So your primary outcome there was a little bit woolly. I wasn't quite sure which one you chose. I'm going to ask you to commit to choose a primary outcome. Okay. And one of the things leads on from Graham's comments. Is this not more about qualitative research, trying to establish what the barriers are for moving towards what we feel is a better pathway?
So, well, in terms of the first part of your question, what should the primary outcome be? I think I've been slightly, my primary outcome would be adverse clinical rates. That would be the adverse clinical events, so number of readmissions with sepsis or bleeding. That would be my personal thing, but my academic supervisors leading me into the direction of healthcare uptake and the cost aspect. What was the second part of your question?
Yeah, so the second part was...
why not qualitative? I think there's a decent reason for that, in that at the moment, as I mentioned a few times, is we don't know that primary treatment is better than delayed treatment. So I think that wouldn't be qualitative. That is hard facts. I mean, what is the length of time to stone free? That's not qualitative. That is number of days. You would get a difference between somebody who's treated within 24 hours and somebody who's treated 3 months down the line. That's not qualitative, that's quantitative.
Okay.
We've got about a minute left, so I'll go over to the two Johns.
Yeah, thanks, Joseph. So there isn't currently an Uber app where you can dial up a urologist with the ureteroscope and the laser within 24 hours.
No.
And that's critical to this study, isn't it? Have you any baseline data on what the service provision looks like? How many units can actually offer that service? Because that doesn't need to run patients through it. You could ask that question up front.
Sure, and I have been asking around. I mean, I must admit it's been informal, but with my registrar colleagues, and the current estimate is about 10% of patients that they're performing an intervention on are getting a primary ureteroscopy. So if they perform 100 stents, 10 of those would have got a primary URS, and I think you could extrapolate that across the different hospitals that we rotate to. But there is no formal documentation about which centres are able to offer primary URS and which can't.
Thank you.
So I'll make my last comment a quick one. So you've shown a great observational sort of setup there. In terms of patients and involvement in this so far, have you involved any patients, and do you have any views on how their view of your study and your endpoints are?
That's a really good question. No, I really hope to, and that's something that we will take on board, but as yet there's not been patient involvement, but I totally agree with you, that's key, it really is key. Thank you.
Joe, thank you. We've run out of time for audience questions, so we'll move on to the next one. Thank you,
Thanks,
Joe. Simon Morton to present his project.
Good afternoon. Thanks very much to Burst for allowing me to come today to present our idea for a multi-centre prospective study evaluating the incidence and outcomes from emergency scrotal exploration. I'm currently a registrar up in the northeast. This came about because as a registrar, I'd noticed I felt that we were doing a lot of explorations for negative pathology with no findings found at operation. And then when I rotated to the Freeman, Chris Harding had been speaking to Greg Shaw at the NIHR committee, and they'd had similar discussions, so we decided to do a multi-centre prospective study within the region, which I'm presenting tomorrow. So today I'd like to just give you an aim of what we want to do and an introduction to the subject. I'll discuss some of the previous studies, discuss our proposal in detail, and then summarise. So really we want to identify the incidence and outcomes from males undergoing a scrotal exploration for acute scrotal pain. We hypothesise that a large number of scrotal explorations are for negative pathology and don't require doing. I think a large-scale collaborative study would help address this and investigate further. Acute scrotal pain is extremely common. I'm sure many of us who are on call as urologists see this. I see it week in, week out when I'm on call. But the key thing is, what are we doing with regards to the investigation and management of acute scrotal pain, both here in the UK and internationally? On the next slide, I'll discuss some of the previous studies, but there's a lot of small studies out there, mainly retrospective, looking at this. But I don't think currently we have an idea of what we're doing. And then the other key question is why do we need to reassess our management of scrotal exploration? Too many explorations, as I say, we think we're doing for negative pathology. Orchidopexies are getting done that are not required. And hopefully this would improve patient outcomes if they weren't needed to be done. We can avoid unnecessary complications. In theory, there's with orchidopexies, you can get anti-sperm antibody formation, especially if it was done when there was no pathology to be found. And can we use a better use of resources we still are in austerity at the moment. So with previous studies, there's an awful lot of studies in the literature. I've just selected some, but you'll find far more. And as you can see, a lot of them here are retrospective, starting at the bottom with Jefferson et al. Number of patients, 115. They found torsion in 72%, and then the tortidatatid in 24%, and 4% epidermolysis. And similarly, the other studies, relatively small numbers, and the pathologies found at expiration tend to vary, with the findings of torsion differing there from 11.5 up down to the 72%. The other thing to say is a lot of these studies aren't reporting any negative findings. Interestingly enough, there was one prospective study from Chris Goodman's group in Dundee, and he reported 10% negative pathology. The other thing I'd suggested in the application for Dragon's Den today was what about a scoring system? Could we get a benefit from this? I started out in the pancreatic unit as a house officer in Glasgow, and we used the IMRI score, which had been designed there by Clem Imrie. So we could use this as an adjunct for clinical diagnosis and also as a stratification tool. I think it would also facilitate communication. Quite often I go down to the emergency department. I sometimes find A&E doctors who are often saying to me, would you mind just popping in and having a look at this patient? I'm not quite sure what's going on. I don't think it's a torsion, but it might be. So maybe if we had a scoring system, they could then use that to help communicate with ourselves. A group in America have looked at this previously in 2013. They called it TWIST, Testicular Workup for Ischemia and Suspected Torsion. Through their study, it was a prospective study of just over 300 patients. 51 of those had torsion. And then they prospectively validated it, and then they did a retrospective separate cohort to validate this. And they came up with testicular swelling, hard testicle, absent cremasteric reflex, high riding testicle, and nausea and vomiting. And in brackets is the points they gave to it. And they found the upper limit for low risk was 2 or less, and the upper limit for high was 5 or more, 5 up to 7. And they reported positive and negative predictive values of 100% for both of these, at the 2 and the 5. And they were saying patients in between, they're the ones that then proceed to do an ultrasound scan to see what was going on. Last week we also had the Twitter poll. Thank you to Burst for organising this. Interestingly, late patient presentation came out on top at 38%. I actually voted for the CPOD theatre delay, which came out at 31%. And this is something I think late patient presentation we could address in our study, which I'll come to. Oh, sorry. So as I said, tomorrow I'm presenting our 6-month retrospective multicenter study within our region. But I'll just give you a little snippet today. 116 patients over the 6-month period. The median age was 13. We looked at transfer time, it was 45 minutes. And the median time to theatre was 90 minutes. As you can see here at the top, we found 30% negative explorations with no pathology found, and only 20% testicular torsion. There was 30% tortidatatid, and 18% epidermolysis. The key thing here is 41% of the patients in this study had orchidopexy, so 21% of patients were getting orchidopexy that was not indicated. So just give an outline of what we're proposing. We'd want to look at all patients presenting with acute scrotal pain. We would exclude those with trauma or testicular tumour. We can then look at the transfer time from referral then admission. We want to take demographics, clinical assessment, investigations and management. That would then lead on to a follow-up study. We could look at immediate post-operative complications, for example. And in our study, we did a 6-week telephone follow-up and we got a 72% response. So in more detail, age I think is very important, and I think we would do a subgroup analysis looking, for example, at the paediatric population as well as the adults. We want to look to see if any previous surgery and the time of presentation. This would allow us to then assess from that Twitter poll that people are thinking late presentation as a factor. We can look at transfer time, clinical assessment, history, pain. We want to look at pain really in detail. Children, we could use visual analog scale. And adults, we can use scoring systems to really try and validate. And then we look at all the usual symptoms that might be associated in the history. And again, the examination findings as well. Investigations, we'd want to look at urinalysis and blood tests. And we'd be interested in an ultrasound scan if it's done. We would not be asking for an ultrasound scan to be done. We'd look at time to theatre, and then the management, we want to know, was it conservative management, grade of surgeon, operative findings, operative technique, was there any re-exploration? As I've already said, post-operative complications we'd like to look at, and a 6-week telephone review. So to summarise my talk today, I don't think we know really what's going on with current practice. I think a collaborative study would then allow us to establish what the current practice is. We may then be able to create a score that's validated, not only with clinical components, but also possibly with laboratory components. This might lead to a change in practice. Importantly, it could improve patient outcomes. If there's late presentation being found, we could consider doing patient and parents. A lot of these are children, about education possibly in the primary sector, and rationalise resources. This could then lead on to further studies, for example, looking at the role of ultrasound scan. Thanks so much for listening. Happy to take questions.
So this is a very important topic, and it did bring up one of our biggest debates on Twitter, actually, and quite a few passionate comments. So I'd like to start with the other end of the table this time. So, John, your comments and feedback.
Okay, so great presentation, and I really like this project. But if we're cutting to the bottom line, the key end game seems to be decreasing the exploration rate and negative findings. And I guess the real question is, what's the acceptable miss rate? Is any torted testicle acceptable? What's your view on that? And do you see this ever going any further than an observational study?
I don't think missing a torted testicle would be acceptable. It's just going to couldn't have that. But I think it's a case of we can even reduce. There's an awful lot of negative explorations being done. So while that's to help looking at scoring systems put into it, but also possibly the role of ultrasound. Now in the UK, we don't tend to use ultrasound that much. I've spoken to a friend of mine who's been out in America, and they tend to use it much more there. Whether or not that would delay things, I don't know, but I think clearly we're doing far too many. I need to reduce epidermocaitis. There's a lot coming to the theatre as well. Ultrasound might be useful once we find out what is the current practice, to then assess and use that possibly to pick up any epidermocaitis and hydatids. The other thing is, I used to think, oh, we should take out all the hydatids, but then, as you know, in the northeast, we do 3 months paediatric surgery, and a lot of the hydatids there we're picking up clinically, but they're also getting ultrasounds, and they're going home with analgesia. They wasn't coming back with problems. So that's another thing, it's a high rate of that. The thing is, I think nationally and internationally, we just don't know what the rates are. All the studies, these very small studies, so a large-scale study might then allow us to actually see what is going on.
Thanks, Simon. A really important topic. And a very practical question is that torsion and its management, I'd advise, is a bit of a turf war in most hospitals between general surgery and urology. Do you think in terms of getting your data requirements, it's going to be difficult to meet the general surgical registrar who's been up all night and say, "Gal, you've been doing torsions, could you fill the form in?" How are you going to manage the data acquisition?
I think some of them are engaged. It's still in their ISCP curriculum for level 4. In my region, one of the district generals, the surgeons do the torsions out of hours, so they don't refer them to me in Middlesbrough. I think they probably engage with it, to be honest. We did look at transfer times, wonder if there's any problems there, but the surgeons are referring them into us. As I say, one of the district generals, they are doing them.
Okay, thank you.
Again, I echo that it's a really important topic, and one that we're currently doing a systematic review in for torsion technique in burst. So torsion's a big area. So there's the diagnostic approach, there's the technique, and there are long-term outcomes. Can you give us an idea of how you'd use some of the information from this to guide your further management and how you might improve patient outcomes?
So once we get an idea of what the current practice is, one study I thought, if we're going to look at for ultrasound, for example, we could do an on-table ultrasound. So we could either just do an ultrasound for everybody that's coming to theatre, it shouldn't cause a delay, or we could do a randomised trial, if you like, and just randomise who gets an ultrasound, who doesn't. That's one option.
Because my proposition to you would be, if we think that we want to improve the diagnostic approach and reduce the negative exploration rate, we should focus on a diagnostic study using ultrasound to see whether or not that helps. And there's the practicalities of that in a urological surgical setting overnight, etc., rather than necessarily spreading our ideas over a range of different areas.
The other question is, as urologists, should we start learning some ultrasound in this area? I mean, one of my colleagues now can do ultrasound. He's gone and done training.
So, telephone calls response rate 70%, what do you think that impacts on your findings potentially if you scaled that up, and how would you try and fix that?
One thing is we can still do the telephone, or we could try and do a written follow-up as one option, because we'd said to the patients they were happy, they agreed to the telephone follow-up, but then it's sort of 6 weeks down the line. Why don't we bring some sort of written paperwork into that to help with the follow-up?
So do you think 70% is acceptable?
No, I'd want to see higher.
How much?
As high, well, as high as possible.
Very political.
Oh, thank you to the dragons there. Is there any questions from the floor? Asad Ali at the back.
He's very loud.
Clearly, acute scrotum is an important area, and to be commended on presenting projects for that. I wonder, though, whether you might consider restricting the study to a particular range of ages, because to my mind, the management of the really young kids is always going to be different to those of what is actually the peak age group in the sort of late teens, early 20s. The young kids, you're really compromised by your inability to get a decent history, the fact that you can't, you've got worried parents, and so on. And I wonder whether you'd actually, if you were looking to try and reduce the numbers of negative explorations, you'd actually be better off looking at that group where the peak incidence is, and where also you might have better luck with some sort of screening tool or something like that, rather than trying to capture the whole lot.
Well, that's what we're saying about maybe splitting up into a subgroup with the age. Certainly in our study, the median age for the data, I think, was 10. Tourism, we were 17. So the data tend to be in the younger group.
What I was getting at is that you might want to just start by leaving those out and then concentrating on sort of almost the 16 plus or something like that, because I'm not sure you'd be able to get a stratification tool that's going to work across the entire age groups, just because of the difficulties in getting a history from the younger ages.
I think we need the data to demonstrate your hypothesis before we do that. Just to pick up on a couple of points made by the panel. So John's quite rightly pointed out, John Anning, that the end game here is reducing the number of negative explorations, and Viru's talked about a diagnostic study. And I can see the end game from this being a cohort study with ultrasound done by a registrar just prior to an exploration on the table being recorded. So there's no risk to the patient. They all are going to go down standard pathways. They're going to get explored. But, what is the performance of the average registrar with an ultrasound probe in their hand prior to surgery? And that's what we don't know. And if we demonstrate actually that the miss rate is going to be very low, and we also demonstrate a significant complication rate from scrotal exploration, we've all seen scrotal hematomas come back after exploration, then you start to get towards equipoise. You start to get towards powering an RCT, perhaps. But it's a difficult one. I mean, the Twitter poll stirred up a massive storm about what we should do with regards to ultrasound scanning. But I think that's kind of what I can see in the future from this. But, we sit here in 2018, and the diagnostic test for testicular torsion is an operative procedure with a 20% positive predictive value. That can't be right, can it?
I think we'll move on from that. So thank you, Simon. Now invite Nikita Bhatt to present her project.
Good afternoon, everyone. I'm presenting what we're calling as the MPOS study on behalf of Tala University Hospital in Dublin. So ureteric stents are commonly used in urology, and almost 80% of patients after ureteroscopy are stented. There have been a few studies, and even the EAU guidelines would state that a stent would not be necessary after every ureteroscopy, especially the uncomplicated one. But a worldwide survey of urologists published in the Journal of Endourology in 2012 showed that almost 64% of urologists always stent their patients. Stents, I would describe them as a necessary evil. They're evil because our patients don't like them. 6 out of 10 patients would complain of pain, lots, increased use of analgesia, and at times increased hospital stay after stent insertion. But at the same time, they are necessary because they reduce the pain and obstruction that is caused by ureteric edema, and they're thought to reduce the pain caused by blood clots and residual stone fragments. It is important for us as practicing urologists and people who use stents all the time to know what is the optimal duration that a stent is required after ureteroscopy for urolithiasis, because we need to strike a fine balance between reducing post-operative adverse events and at the same time reducing patient morbidity. It is important for us to have an objective basis for our clinical decision making. 2 studies have looked at this in the past. Both were retrospective. The first one was a Japanese study, and they compared a stent duration of less than 14 days to over 2 weeks and found that the less than 14 days group did better with respect to post-operative adverse events and less antibiotic use. The other study was conducted about 5 years later in the US, and they compared much shorter stent durations of 3 versus 7 days. And they found that the shorter duration of 3 days was indeed not enough, and they showed worse outcomes significantly with increased post-op events and flank pain. So what is the optimal duration? Well, we took the help of our urotutorati, and we conducted this poll to find out, and the question we asked was, where a JJ stent is felt to be necessary, post-ureteroscopy or uretropiloscopy, how long do you typically leave the stent in for? As you can see from this graph, nearly half of our respondents said 4 to 7 days. There's a good 15% who said over 2 weeks, and a good 10% who said 1 to 3 days. We hence found that the worldwide practice was very variable. We made a lot of interesting notes based on the enthusiastic discussion that followed this poll, and we found that currently there is quite sound clinical basis for our decision making, but there's little scientific data to back this up. Logistics do play a role, for example, access to flexible cystoscopy lists. Different stent removal techniques are being used around the world, and there's always a bias of like-minded people on Twitter, which we need to keep in mind. Based on this, our research question poses the question, what is the optimal duration of stent placement after the final ureteroscopy or piloscopy for urolithiasis, where a stent is felt to be necessary? And by final, we mean patients who have completed their stone treatment and who are eligible for stent removal. Our hypothesis is a shorter duration of stent placement may be equally effective as a longer duration, but we need to know what. The study design is going to be a prospective multi-center observational cohort study, and the follow-up period ranges from 6 to 12 weeks from the point of recruitment. So the recruitment will be at the time of their stent insertion. We'll then document the stent removal date and method, after which the plan would be to follow these patients up at least 6 weeks after the stent was taken out with a clinic visit with a detailed history. The imaging and investigations ordered at that stage would be at the clinician's discretion. We are planning to include all patients who undergo stenting, as mentioned before, and who attend our follow-up appointment as planned in the study design. These are our exclusion criteria. So we're excluding bilateral stents, abdominal anatomy, ureteric wall injury, dilatation procedures, sepsis, stents left in for over 6 weeks, and patients who require further endoscopic stone procedures. So no added intervention is necessary for this study. The insertion of the stent will be as per the clinician's discretion and in accordance to whatever is their usual practice. Our primary outcome focuses on the incidence of adverse events within 6 weeks after stent removal that require unscheduled clinician contact. And this could be either by a phone call, a GP visit, or even an ED presentation. Our secondary outcomes would look at things like indications for stenting post-ureteroscopy, unscheduled clinician contact while having the stent in situ and complications during the same time, any requirement of early investigations, reinsertion of the stent, and any other abnormal findings that you note on the follow-up. We plan to collect several variables which may affect our outcomes, and I've divided these into 4 specific categories, the first being the demographics, the second the operative variables, then post-operative pre-stent removal variables, and post-operative post-stent removal variables, and I'll just take you through them quickly. So these are the demographics. Operative-wise, we want the type of ureteroscopy, access sheath use, pre-op stents, hydronephrosis, stone laterality, location, size, impaction. What intervention did you do, and why did you insert a stent? The variables we want when the stent is in situ would involve unscheduled clinician contact, what stent symptoms did the patient have, were there any stent complications, any medications used, and the stent removal date and method. And finally, the post-operative post-stent removal cohort will look at post-operative adverse events with options like fever, colic, etc., any unscheduled clinician contact, imaging, tests, medications, restenting, and any other abnormality. Our analysis is going to focus on a subgroup analysis based on rigid and flexible ureteroscopy, which we'll analyze separately. And we're going to divide our stent duration into specific groups like our Twitter poll into 1 to 3 days, 4 to 7 days, 1 to 2 weeks, and over 2 weeks. Statistically, we'll use appropriate statistic tests to calculate the post-operative adverse events based on their post-operative stent duration. We'll then use a multivariate logistic regression analysis to try and see if any of the variables we've collected affect our outcomes. If we were to extrapolate this study into a randomized control trial, we also powered the study. And we found, based on the previous studies that I presented, that the number of patients required in each group would not be huge if we were to conduct a randomized control trial. I apologize for the SPSS there. In summary, we think this study is appropriate for a platform like the Dragon's Den because it answers an important clinical question in a very commonly performed procedure by all of us, including trainees. As we have seen, there is currently a lack of guidelines or even high-quality studies on the optimal stent duration. Our study design involves little deviation from routine clinical practice in line with previously successful projects. This makes the ethics process quite clear and easy, and hence it is easier to collect larger numbers. In addition, we have a shorter follow-up time, which translates again into greater compliance and larger numbers. I thank you all for your attention and welcome any questions or suggestions.
Brilliant. Thank you, Nikita. Another clinically important topic, and actually seems to be in keeping with the theme of personalized, stratified care for our patient rather than using overarching data. So this is something I'd go back to the Dragons, and we'll start in the middle with John McGrath.
Thanks, Nikita. Could I just clarify, in terms of patient symptoms, how are you going to get that data? Is that from the notes or from patient-reported outcome?
Patient-reported. So we're planning to conduct a combination of reported outcomes and notes that were taken by the clinician as well, and then see if we'll have a range of criteria, and if they fulfilled all of that, just to stick yes or no. Okay, because I'm not an endourologist, but I think there's a validated stent quality of life questionnaire which you might want to think about using as well. So, okay, thank you.
Viru?
I was actually going to ask the same question. So I think in this particular topic where you're looking at how long a stent's going to be in for, patient-reported outcomes are really important. I mean, I guess my question, in absence of that one, would be related to barriers in doing this. So say you find that there are more adverse events in one group than the other. You remarked about some of the barriers in changing that. How will you capture that data?
So if there are any barriers, you mean by shorter times or versus longer times? I suppose we first need to know what the barriers are. And again, logistics would be one of the reasons why a stent is left in for shorter or longer. But if we can conclusively prove that this is the duration that you need the stent in for and not any longer or maybe not any shorter, then you're more likely to achieve greater compliance, and also the whole debate whether to leave a stent in a string or not. We'll be able to answer those questions better if we have this kind of data.
Graham.
Okay, so my question's around the duration of stenting. If you're not sure what the optimum duration is, why are you grouping them into categories already?
The reason is because that's the kind of average, or what is most used in practice, is why we chose these groups. But obviously from whatever we get, if we see a trend that is going against what we've decided, we're open to changing that.
So what I'm getting from that is there's two things. There's the intended length of stenting, and then there's the actual length of stenting. So is it important that you record both of those, or is it only the actual duration that's important?
In this study, it will be the actual duration, and based on then we can inform decisions on the logistics, and then we can have a debate about whether this is intended or actual. Because I think at the moment we just don't know, and it's usually 5, 7, just based on clinical judgment as opposed to.
So a tip is to use the actual duration, because there's much more information in that than falsely creating categories.
Yeah, and finally, John.
So, look, I think great presentation and important problem. I would classify this as a project, and I'll throw my neck out there saying that I don't think this is a good collaborative project, but I think it's an important project. And therefore, what you might consider doing is firstly getting some pilot data to get an outline of what's going on. And then secondly, this would be ideal for a collaborative with endourological surgeons to get buy-in, because the data that you've got there is complex and detailed, and actually practically then setting up a study is valid, but in centres that can deliver it, okay? And that would get over your barriers issue. But I think, great presentation, great work.
Thank you. Darren Smith's just trying to make a comment, if that's all right.
Just what? Is there a mic on the floor? I'll go.
So this is a big problem for us as stone surgeons, and we're interested in it. We were interested in your Twitter feed. One of the, and I replied to it, and it depends upon the indication. To answer the question about how long people are leaving stents in, it's often not a judgment. It's based on something that's very practical. So, for example, if you put a stent on a string and you've got an operating list on a Monday and you remove the stent in a clinic, and your clinic is on a Thursday, it's going to be 3 days. If your clinic's on a Friday, it's going to be 4. But I think the key to all of this is the morbidity that happens after the stent is removed. In other words, are you leaving them too long or taking them out too quickly? So I think that this has got actually quite a lot of legs, and we'd certainly collaborate with it.
Any other questions from the floor? It's like I'm about to sing.
Could I come back on that question, that point from Darren then? Darren, if that's the case, that you take them out based on something like the convenience of the clinic, then that's the same as a randomized trial. That's what you call in economics an instrument. The decision to take it out is not something that's informed by anything that's related to outcome. It's as good as being at random. So if that's the case, you've got a cracking study.
Exactly.
You would have a trial without the expense of having to fund a trial.
Any other? Oh, yeah.
Just wonder with something that just said about when you take out the stent, if you do it quickly, the string could actually affect your prom data, and then so you leave it in 2 weeks to, have it. The practicalities of getting, I don't know many units that can get a flexible cystoscopy stent removal within 3 days. So at the end of the day, you may answer the question that 4.3 days is the ideal time to remove it, but maybe it's miserable to be with a string, so you'd avoid that, and then no one can actually deliver 4.3 days because they can't get a flexible cystoscopy in that time because of all the 2-week wait patients. So you have to, would you consider changing your trial based on those more mandatory practical considerations?
I suppose what we're trying to collect is, once we know the duration, we can then try and inform those practices, because to my understanding, those are because there's no guideline at the moment, we're using practical reasons to try and remove the stent at X date. Whereas if we do have a reason to say that it's justified that the stent needs to come out in 4 days, which is why I would leave it on a string versus do a cystoscopy.
I'm really sorry, I'll have to stop it there just because we're overrunning, and we'll let the debate continue at the end of the session. Can I thank Nikita and actually all three of our presenters? We now have 3 minutes while Ken will summarize, and could you all please get voting on the app, because the audience vote counts in this, and I'll give a chance for the Dragons to also tally up their scores.
Could I just have the introduction? So these are your 3 options for Twitter, and we did a little summary of working through the different presentations. 3 fantastic presentations and proposals, and we've heard the kind of pros and cons of each. Just talking through, you guys may feel the same as what we did. With regards to the Uber trial, a very well thought out project, methodical in its approach. One of the things, they've not done any pilots yet, so it's difficult to ascertain whether it's totally implantable, but it could be suitable to trainee collaboratives. With regards to Simon's project with scrotal exploration, is a very important study question, as we could see from the discussion that was taking place with a low negative predictive value, but also the study design. Is there maybe more arms or areas for development that we need to look at before rolling it out to a burst level project? And then Nikita's project was again presenting on something that's very common and important in clinical practice and could potentially be rolled out. One of the things I thought about was again measuring the adverse events and how they were going to be recording from a practical sense within kind of burst. Getting or phoning GPs practices to see if there's been any contacts might be quite tricky. So as I say, there's loads of pros and cons, loads of pros, not many cons. So hopefully there's been a good result today. So hopefully we should have a winner. Oh no, we've got to vote first. Is voting finished?
Everybody's managed to vote. I'm just waiting for the outcome from our Twitter vote. And I can see Sasha at the back, frantically trying to pull it. Sasha?
Unfortunately, we put the medical student doing quick maths at the back of the room. It's unfair.
I suspect it won't make a difference.
Okay.
We've only 6 votes and there's 2 for each, so it doesn't make a difference.
Okay, good.
It's gone up again.
Yeah. Okay. Maybe this is a future project for Burst. working on social media voting. Okay. So, as I say, 3 absolutely fantastic presentations today. We've got the president of BOWS here to give the presentation to the winner. So can I ask the president to come up to the front, please? Thank you very much. And the winner of today's Dragon Den was Simon Morton. Thank you very much. Cheers.
Guys, this has been a fantastic session. I've learned a shed load, and it's just amazing to see what the Burst Collaborative has achieved over the last couple of years. So congratulations to the group, and I wish you well in the future. This has legs, and it's going to run and run. Well done.
So as we said earlier on, there's a dinner tonight. We've got about 10 spaces left, so if you want to form an orderly queue at the front, then you can come and get a space. Thank you.
Well done. Really good.